Welcome. My name is Danielle Getz. I'm Associate Professor of Pediatrics at the University of Buffalo and the CF Center Director there. And I have the pleasure of co-chairing this symposium, the CF Year in Review, with you today. My co-chair is Dr. Richard Simon, who's Professor Emeritus at the University of Michigan. And he's also the recipient of the Richard C. Talamo Distinguished Clinical Achievement Award from the CF Foundation in 2021. It's exciting to be with you today to have 4 different talks. So we're sorry for the size of the room. We thought it might be a little bit bigger for this review, but we do have 1 microphone at the side, so we will have questions after each talk. So each talk will be 20 minutes. We'll have 5 minutes for questions. And please use the app, because I know it's hard to get to that microphone over there. So we'll be monitoring the app for any questions. So the speakers today had the challenging effort of trying to condense a lot of information for each topic into 20-minute talks, but I assure you they've done a great job. So today we're going to learn about the most up-to-date information from this year on CFTR modulators in children, and we're going to also hear about pulmonary exacerbations, advances in GI disease, and also advances in CF-related diabetes management and diagnosis. So I'd like to introduce our first speaker, Dr. Jessica Pittman, and she is an associate professor of pediatric pulmonology at Washington University School of Medicine. She also has a master's in public health and epidemiology. Her roles at Washington University include co-director of the Cystic Fibrosis Therapeutics Development Center, associate program director for diversity and inclusion at the pediatric residency program, and also the faculty leader in the Office of Diversity, Equity, and Inclusion. And today, Dr. Pittman is going to talk about CFTR modulators in children, nearing primary prevention. Okay, so I just have to go back and forth, and then this will work.
Hi, everybody. Thank you, Dr. Getz, and to Dr. Simon for inviting me to speak today about modulators in children. Here are my disclosures. So we're going to start today talking about primary prevention and move then to talking about advances that we've learned this year in our understanding of the impact of modulator therapy on the respiratory and pulmonary health of children with CF. We'll go from older children that I'm defining as 12 and up to school agers 6 to 12, and then preschoolers and infants. We'll touch briefly on the potential impact of prenatal modulator therapy on infant health, and then move to concerns regarding adverse neuropsychiatric and neurocognitive effects and the implications of differential access in the modulator era. And we're going to try to do this all in 20 minutes, so buckle up. Let's talk about the role of modulator therapies in primary prevention. So we typically define primary prevention in CF as the prevention of CF pulmonary disease at its origin. And we know that if we look closely, we can find evidence of CF disease long before children are symptomatic, even in infancy, whether that's by bronchoscopy, by imaging, or lung function testing. And thus there's a window of opportunity somewhere either before birth and into infancy where our interventions could truly stop CF pulmonary disease before it has a chance to gain a foothold. We're now moving into that space with our modulators in the US. As you can see here, 3 of the 4 modulators that are approved in the US are approved into the preschool age range, with ivacaftor now approved at 1 month of age and up, lumacaftor ivacaftor at 1 year of age and up, and elexacaftor, tezacaftor, ivacaftor at 2 years of age and up as of this year. So what should our considerations be for eradicating CF lung disease in the modulator era? First, personalized interventions for each patient beginning at birth would be ideal, of course. And we need to define optimal timing of interventions to achieve the greatest clinical benefit with the fewest side effects and the lowest cost. And this could include considerations around initiation, duration, and interval of treatments. We also need an improved understanding of CF endotypes, which are defined as a genotype and phenotype subpopulation, to better identify patients most likely to benefit from early intervention, likely those with the highest risk of significant early disease, and ideally those with a lower risk of significant side effects. And finally, we have to balance the potential risks of long-term drug exposure with the potential benefits of early therapy for each patient. So, what have we learned about modulator therapy in older children this year? Let's talk about lung function as well as structural disease. This was a study from Europe and Australia, which was a randomized control trial of ETI versus TEZ-IVA in children and adults aged 12 and up, and 30% of the subjects were in that pediatric age range. They were randomized to receive either drug for 24 weeks. And what the investigators found was that ETI was superior to TEZ-IVA both when it came to symptoms, as you can see on the left, with the CFTR scores being higher in the ETI group in blue, and with lung function with an increased FEV1 on the right, with the ETI group compared to the TEZ-IVA group. Of note, and this will be a running theme, there were 3 subjects who discontinued drug secondary to neuropsychiatric AEs. Next, we'll move to a study of 24 children at a mean age of around 14 years, looking at both the lung clearance index by multiple breath washout as well as MRI after ETI initiation. These subjects were tested twice, 1 year apart prior to starting ETI, and then once after ETI. And again, the investigators found improvement in FEV1 and LCI with ETI. So as a reminder, the LCI on the left is the lung clearance index, or the primary outcome measure for multiple breath washout testing. A lower LCI is better, as opposed to an FEV1 on the right, where a higher FEV1 is better. And a subset of these patients had already been on other modulators before initiating ETI. These investigators also found significant improvement in lung ventilation, perfusion, and morphology after ETI initiation. Since I'm not a radiologist, I will not attempt to interpret these in detail, except to say I appreciate the images the authors also gave us, where you can see an improvement in structural disease in this one patient before and after up top, and a correlating improvement in ventilatory defect down below. And one last subject in school-age children as well as adults, although this population of 117 individuals, the majority were under 18, showed that ETI improved, again, the lung clearance index as well as structural disease by CT in older children. And these subjects were studied at baseline, 6, and 12 months after ETI initiation, and over 50% of them had been on a modulator prior to initiation of ETI. And again, the investigators found improvement in both FEV1 and LCI that was sustained out to 12 months, and improvement in lung disease on CT by both percent disease and percent mucus plugging when we look from baseline to that 12-month marker. So not surprising, but definitely exciting that we see improvement in lung function as well as structural disease on ETI therapy in our older children. Let's look at our school agers. So this is a study of ETI in 6 to 11-year-olds who were delta F508 and minimal function heterozygotes. There were 121 children, and they were randomized to either receive ETI or placebo for 24 weeks. And again, the outcome measures were LCI, FEV1, CFTR, and sweat chloride. The authors found significant improvement in both LCI up top, where you can see a drop in LCI in the ETI group, again in blue, compared to placebo in gray, and an improvement in FEV1 on the bottom. They also showed improvement in CFTR and sweat chloride. I thought this was a nice parallel or correlate study. This is a retrospective study of 9 children with severe lung disease prior to initiation of ETI with an FEV1 of less than 40% that showed, again, improvement in lung function after ETI initiation. These children seem to have a more gradual or prolonged response in terms of their improvement in FEV1. You can see, as opposed to the previous slide where subjects had a rapid change and then seemed to enter a period of stability with a plateau in lung function, these children are still having an increase in their FEV1 at week 24. And finally, in our school agers, this was an open label extension study looking at the long-term safety and efficacy of ETI in school agers. There were 64 children aged 6 to 11 years, followed for a mean treatment period of 94 weeks. And the authors found sustained improvement in lung function, again, FEV1 on top and LCI below. You can see the rapid improvement with initiation of drug, and then again, now we have this really impressively long, sustained improvement. We're going into years of stability of improved lung function on modulator therapies, which is really exciting for these kids. The authors also showed improvement in BMI and weight for age Z-scores that, again, were sustained now to that 96-week mark. All right, so we've got some great news in school agers. Now let's look at our preschoolers. We're going to briefly touch on lumacaftor, ivacaftor for 2 studies before talking about ETI. This is a study of lumacaftor, ivacaftor in 2 to 5-year-olds. It was a phase 2 study looking at LUM-IVA versus placebo for 48 weeks in 51 children. The authors found perhaps less of a difference in LCI between the lumacaftor-ivacaftor group and placebo, but did note that the LUM-IVA group had fewer pulmonary exacerbations than the placebo group. And they also saw some improvement in structural disease and perfusion on MRI. In 1 and 2-year-olds with LUM-IVA, this was an open-label phase 3 study of 47 children, the authors found the expected decrease in sweat chloride that you would see out to week 24, along with the rebound at the safety follow-up, but excitingly saw a possible improvement in fecal elastase, with a mean change in fecal elastase of 73 micrograms. You can see there's a lot of scatter in the individual plot down below, but some of the subjects did move from the pancreatic insufficient range below that dotted line to what we would consider pancreatic sufficient above the dotted line. And now let's talk about ETI in our preschoolers. This was a phase 3 open label study of ETI in 2 to 5-year-olds, part A being a 15-day pharmacokinetic study, and then part B, a 24-week safety and tolerability study. There were 75 children at a mean age of about 4 years. Again, thinking about neuropsychiatric issues, in part A, even in that short 14-day window, there was one child who had discontinuation of drug because of abnormal behavior of hyperactivity, aggression, and enuresis, and 5 subjects who had drug interruption, some for the more expected rash and elevated liver function testing values, but some because of fecal or urinary incontinence as well as aggression. Unlike the LUM-IVA that we just looked at in 2 to 5-year-olds, these children did seem to have an impressive improvement in lung clearance index on ETI. Now, there's no placebo to compare with, but the delta is much bigger, and it was sustained out to 24 weeks. And then they also had an improvement in BMI Z-score, as you can see in the bottom right. And again, an improvement in fecal elastase, at least for a subset of subjects, with 6 children, or 8% of subjects, moving from that pancreatic insufficient range below the dotted line to pancreatic sufficient range above by the end of the study. This could suggest that there's a possible window to rescue pancreatic exocrine function in young children in at least a subset of our patients with CF. And lastly, I think it's important to talk about the real-world impact and implications of modulator therapy, specifically our patients' desire to modify other parts of their therapeutic regimen. Here are 2 studies, one of parents of children with CF as well as adults, that found that 34% of parents had altered the airway clearance regimen for their children after initiation of modulator therapy. And in the Simplify study in individuals 12 and up, patients were randomized to discontinue either hypertonic saline or Dornase alpha, and there was no significant change in FEV1 after 6 weeks. This can suggest that our patients want to discontinue some of their other therapies, and that there are ways for us to work with them to do it safely, while also monitoring for side effects and changes in symptoms and lung function. Now let's talk about prenatal and newborn considerations. There are several case reports of the utilization of ETI in utero to treat meconium ileus. Here's one of 2 different fetuses diagnosed with meconium ileus at the 21-week ultrasound and subsequently confirmed by amniocentesis. ETI was initiated in the birthing parents at approximately 34 weeks gestation, and there was no dilated bowel noted at 39 weeks, so we had resolution of the meconium ileus. However, despite early in utero exposure to ETI, these children still had elevated IRT levels, elevated sweat chloride levels, and a decreased fecal elastase at birth. So we were able to recover some in terms of the meconium ileus, but not fully reverse some of the things that we would see in our infants with CF. It's also possible that ETI exposure is not fully benign in utero. Here's a case report of 3 infants born to birthing parents with CF on chronic ETI management who were found to have small bilateral cataracts at routine 2 to 6 month evaluation. And there have been other studies in other modulators, again, case reports of similar cataracts. Finally, I thought this was a really interesting study looking at the impact of in utero exposure to ETI on immunoreactive trypsinogen, which again is how we screen in our newborn screening. And these authors compared infants exposed to ETI in utero to infants with no variants, known carriers, and infants with CF. And what they found was that ETI-exposed newborns had lower values of IRT than unexposed carriers. Again, those ETI-exposed infants were born to parents with CF and so should be carriers, yet their values were closer to the no variant or quote-unquote normal range. This could suggest that ETI exposure may need to be considered when we interpret newborn screening results in the future. And the ongoing Mayflower study may answer some of our questions around prenatal exposure to ETI. Let's move to talking about the elephant in the room, neuropsychiatric and neurocognitive effects in children. As many of you know, ETI has been labeled newly by the European Commission with depression as an adverse event and recommended monitoring for new or worsening neuropsychiatric symptoms. There are several reports and papers now of neuropsychiatric side effects of ETI in particular, as well as other modulators in adults. This one is a single-center retrospective study of nearly 150 individuals who initiated ETI therapy, 21% of whom subsequently underwent new psychiatric evaluation, with 11% having identifiable new or worsening symptoms, including neurocognitive issues like brain fog, as well as depression and anxiety. And the interventions that had a response varied from pharmacotherapy or psychotherapy to ETI dose reduction or even discontinuation. There are several other reports in adults that suggest that anywhere from 7 to 22% of adults initiating ETI therapy may have new or worsening psychiatric or neurocognitive issues, although it is important to note that perhaps a smaller percentage have improvement of those issues as well. Much less has been published in children and adolescents. Here is a concerning case report of two 15-year-olds who developed suicidality after initiation of ETI. One, a 15-year-old who had suicidal thoughts that improved twice after discontinuation, and a 15-year-old who had 2 actual suicide attempts before symptoms improved with ETI dosage reduction. Certainly concerning and something we should all be watching for. And while I couldn't find a publication around neuropsychiatric effects in younger children, I did find this publication about increased intracranial pressure in children. This is a case report of 3 children aged 7 to 9 years of age who presented with headache, vision changes, 2 had 6 nerve palsies, and then they either had papilledema or increased optic nerve thickness on exam. And they were subsequently diagnosed with increased intracranial pressure. 2 of them had also had elevated vitamin A levels. And for 2 of the 3 children, symptoms improved with discontinuation of ETI and vitamin A therapy. So what we can say here is that the neuropsychiatric effects and the impact of modulator therapy on neurodevelopment in young children remains to be seen. And before we end, it's important to touch on who we're leaving behind as we enter this amazing modulator era for our children with CF. Even prior to the modulator era, we know that there have been marked disparities in CF outcomes by race and ethnicity, socioeconomic status, and gender. People from lower SES with CF have increased morbidity and mortality. Black and Latina individuals with CF have a nearly 2-fold higher risk of death before age 18 than non-Hispanic whites. Black patients with CF average an FEV1 16 percentage points lower than white non-Hispanic patients, even with our biased and antiquated race-adjusted spirometric equations. And BIPOC infants have later presentation to CF clinic, even in the era of newborn screening. Dr. McGarry showed us that there's decreased sensitivity of newborn screening in marginalized racial and ethnic populations, with overrepresentation in the groups that have false negative newborn screen or delayed diagnosis of CF. As you can see here, where white non-Hispanic patients make up 85% of the patient registry in 2020, but only 68% of the group that had false negative newborn screen or a delayed diagnosis, while all other races and ethnicities were overrepresented in that group. Similarly, when we look at modulator eligibility, which is again by genotype, modulator eligibility is significantly lower in marginalized racial and ethnic populations, with nearly 93% of non-Hispanic white individuals with CF being eligible for a modulator, and only 70% of Black or African American patients, and about 76% of Latina patients. What does this all mean? It means that advances in modulator therapy are poised to potentially worsen health disparities in our CF populations. In the US, we know that even prior to the modulator era, racial and ethnic minorities had worse outcomes prior to the modulator era, as I just said. We have an increasing prevalence, although I would argue this is probably more an increasing diagnosis and recognition of CF in racial and ethnic minorities. And again, lower eligibility for modulator therapies in our racial and ethnic minority patients. We have also shown that there's decreased utilization or perhaps decreased prescription of modulator therapies amongst eligible racial and ethnic minorities for unclear reasons that could include provider bias, trust, access, representation, or provider and patient relationships. Similarly, when we look worldwide, we know that CFTR modulators are inaccessible to many low and middle income countries due to cost, and there's overrepresentation of non-white and Hispanic countries in those groupings. As you can see here, where countries with substantial CF populations that have access to CFTR modulators are in green, and those with substantial CF populations that do not have access to modulators are in red. Wrapping up. So, CFTR modulator therapy continues to show great promise for dramatically improving the lives of children with CF. An initiation of modulator therapy in infancy and preschool nears that goal of primary prevention, of stopping CF lung disease before it has a chance to start. That said, neuropsychiatric and neurocognitive effects of modulator therapy deserve significant attention, particularly in developing children. We have to consider the potential harm to developing minds, as well as the difficulty diagnosing neuropsychiatric or neurocognitive changes in infants. What does depression look like in a 3-month-old? What does aggression look like in a 6-month-old? And what is the potential long-term impact of a negative exposure, even if drug is discontinued, on a rapidly developing brain? The risks and benefits of modulator therapy initiation need to be weighed individually for each patient, and that balance is going to differ by age and by the presence of quantifiable or symptomatic disease, among other factors. And finally, disparate access to modulator therapy by race, ethnicity, socioeconomic status, geography, and genotype has the potential to worsen health disparities within the CF community and deserves special focus and consideration. Thank you.
Thanks so much, Dr. Pittman. So I just wanted to ask if there were any questions from the audience. There is a microphone there. If not, you can use the app and put in some questions. One question I had while we're waiting is, Dr. Pittman, what do you think about LCI and the use in preschoolers clinically? Would we ever need it to support our decision to have people on ETI? Right now, it's covered by insurance, and I just wondered, based on your experience doing LCI over time,
I think my impression is that that LCI and MBW testing are still going to be a challenge to implement universally clinically. I would also hope that we are able to continue to have discretion between providers and patients and families around initiation of therapies, as opposed to needing to meet a threshold when it would come to lung disease.
I can't tell if there's someone at the microphone there.
I can't even see where the microphone is.
Yeah. So hearing no one, I did want to ask, you emphasized balancing the risks and the benefits and the personalized medicine, but so we already have ETI available from 2. There's an active study going between 1 and 2. So from all that you've reviewed here and personalized medicine idea, who would you not offer it at the earliest age that they become eligible?
I think that's a great question. Honestly, I think it's a really frank conversation with parents. In my personal experience, when you bring up the neuropsychiatric and neurocognitive concerns, parents respond very differently than if I say, well, I'm just going to check your liver function testing every 3 months. And I've had several parents choose to delay because their kid is doing so well. And we emphasize in clinic that so well does not mean no disease, and I can't prove that they don't have disease. But because it's so hard to know, right, what a 1-year-old with neuropsychiatric changes looks like. I've also had several preschoolers start and have to stop because of clear neurocognitive or neuropsychiatric issues that have gone away as soon as we've stopped drugs. So I think it really is more of a discussion with families, but it's one that at least for me in my clinical practice, I have a lot of discussion prior to initiation, and then it's something that I check on every single visit and emphasize that if there's any changes, we want to know about it and have a dialogue, and I try to tell parents that it's our job as pulmonologists to treat their entire child and not just their kids' lungs. And I'm not doing my job if their lung function's great, but they're too depressed to go to school. So,
along those same lines for neuropsychiatric side effects, what would be your thoughts on like a design of a study to evaluate that?
Yeah, that's a tough one. I mean, ideally we would have, I know you are involved in looking at surveys around neuropsychiatric and behavioral issues in 2 and up. I think it's really hard to assess. I mean, there's developmental scales and things like that, but this is, I think, beyond that into really how do we assess mood and how infants are perceiving the world and interacting with parents. And, and in that same space where we're talking about autism screening and things of that nature, how does ETI overlap? So obviously I'm really excited about initiation of ETI therapy, but it's something I think we have to pay really close attention to in these little kids.
Okay, there was just one question, sort of related on the chat. With the increase in depression in kids in the general population over the last few years, is the incidence of depression in kids with CF on ETI higher than the general population?
I don't think we know at this point. And I think certainly early on in modulator, as ETI was licensed right when COVID hit, a lot of the neuropsychiatric side effects, even in adults, were, at least in my experience, being correlated to COVID and lockdown and all of those stresses. So I think we don't have any good studies to look at that. And we don't have great studies of incidence in depression in children with CF pre-modulator, because obviously chronic disease can lead to issues around depression and anxiety as well. But I think for some patients, there's a very clear change, and for some it can be more insidious, but it just always needs to be a dialogue, right? There can always be a discussion around, should we hold drug for a few weeks and see what you feel like? And do we think we're going to do that much harm holding drug for 3 weeks? Or is it potentially that we're doing more harm if we just keep pushing through for the next 20 years and don't acknowledge this potential side effect?
I think that's a very, very, very good response. Having taken care of CF patients for decades and only the last several years with ETI, I can tell you that anxiety, depression, behavioral problems was very frequent in my practice long before any of the modulators showed up. And that the idea of making sure that everyone is in agreement that it's likely causative in that individual will be really important, because to deny some of the benefits of something that we've all seen, with others, that'll be really important. And so how to do that, I think withdrawal, re-challenge. But having said that, we do know that the benefits, at least the pulmonary benefits of, when you withdraw ETI, they go away rather quickly. And there are reports of people within days to weeks of having significant pulmonary exacerbations. Again, those are anecdotal reports and not. So we have to balance exactly how we do this. It is really going to be critical to get it right.
Absolutely. I do think that in the younger children, because of the lower burden of disease overall, we maybe have a little bit bigger window to be able to discontinue. But yes, we definitely would expect that mucus is going to go back to CF mucus with 3 or 4 weeks off drug. Absolutely.
There are a couple questions in the chat. I'll try to summarize them into one. And then go on to the next speaker. But there was a question about the infant levels of ETI and breastfeeding. And I think that's what you were mentioning, the Mayflower study may help.
Yeah, and if anybody here is leading Mayflower, I can't see faces right now. So the Mayflower study is looking at pregnant parents with CF as well as their infants, and looking at things like breastfeeding exposure and levels in the infant's blood and things of that nature. I don't have all of the outcomes off the top of my head. So hopefully that will answer some of these questions in a more organized manner to get a sense of the incidence of, for instance, cataracts or other things.
And then the other two questions on neuropsychiatric side effects. They're definitely doing a lot of research. And at this meeting, I think they're presenting a lot on those, so we can refer you to those sessions. But also, and the tool Dr. Pittman and I were talking about, there's a preschool checklist to look at these symptoms that are, it's a behavioral and depression and anxiety checklist. So we're working with the mental health committee on that. So thank you so much.
Awesome. Thank you.
Dr. Pittman.
So the next presentation is by Jonathan Kogan from University of Washington. He's in the Division of Pulmonary and Sleep Medicine at Seattle Children's Hospital. Any of you who have followed the literature at all within the last few years of looking at how best to approach patients who are having pulmonary exacerbations, you'll find that Dr. Kogan's name is right at the top of those who have been informing us and particularly challenging us of some of the dogma we've held, for many, many years. So I'm really excited to be able to hear what he has to say, because I think we're all going to have to reassess exactly how we're approaching these patients.
Awesome. Thanks so much for the introduction. Good afternoon, everybody. I feel like I'm lecturing at Hogwarts. I was talking to our fellows about this. It's kind of interesting. So anyway, yeah, so my task was really to look at pulmonary exacerbation treatment over the last 12 to 18 months and then to sort of review some of those studies. These are my disclosures. I am a co-investigator on 2 randomized trials looking at pulmonary exacerbation treatments. So I'm first going to briefly review the USCF Foundation Pulmonary Exacerbation Treatment Guidelines from 2009, and then review over the recently published literature on the treatment of exacerbations over the last 12 to 18 months. And then if you'll indulge me, we'll maybe go into a tiny introduction around antimicrobial stewardship opportunities in the care of people with CF. So these are most of the USCF Foundation Pulmonary Exacerbation Guidelines from 2009. So to orient you to the slide, in the first column, you'll see the various questions that were asked for the task force led by Dr. Patrick Flume to review. Column 2 is the level of certainty, and then column 3 are the recommendations. And I think as you guys, most of you probably are somewhat familiar with these recommendations, but as you can see, there essentially is insufficient evidence to support anything at the time, including the use of systemic steroids, the use of 2 versus 1 IV anti-pseudomonal antibiotics, duration of antibiotics, et cetera, et cetera. So we're going to use this slide and these recommendations to kind of walk through a few more updated studies that have occurred since then. So the first thing we're going to do is, frankly, just a brief review of the STOP2 trial. So I know this is in 2021 it was published, so I'm sorry we're going to go back in time a little bit, but I think it's a really important study and frankly, probably the best study that I've seen that's been done for pulmonary exacerbations. So this was a study of almost 1,000 people with CF, and it was adults greater than or equal to 18 years. And people with rapid improvements in lung function and symptom scores by day 7 were randomized to 10 versus 14 days of IV antibiotics, while those without a robust early response were randomized to 14 versus 21 days of IV antibiotics. And as you can see here with this figure on the y-axis, that's change in lung function, and on the x-axis are the various time points in which the lung function was obtained. And the investigators concluded that 10 days of IV antibiotics was not inferior to 14 days. That's the ERR, or the early responder group. And that 21 days was not superior to 14 days. That's the NER, or the non-early responders. So ultimately, this study really illustrates that extending antibiotics beyond 14 days did not improve lung function, and that in some cases, you actually can just do 10 days of IV antibiotics that seem to be enough for treatment. So I think this was a really well done, absolutely massive pulmonary exacerbation trial and study, and I think it really leads a good roadmap for future pulmonary exacerbation studies moving forward. All right, so a brief word about continuous infusion beta-lactam antibiotics. I'll be honest, I don't think of this at all, but maybe I should be thinking of this a little bit more. So this is a paper that I'll just kind of point you to by Dr. Hong and colleagues, and the goal of this is to provide consensus recommendations for the use of prolonged infusion beta-lactam antibiotics. And this is not CF specific, but does have guidance for some people with CF. And as you can see here, the CF Foundation was one of the many organizations that actually endorsed these recommendations. So I would encourage you to find this paper if this topic interests you. I will say that the recommendations do suggest that prolonged infusion beta-lactam therapy might be preferred to standard infusion dosing for severely ill people with CF. So I think oftentimes we sort of forget that we just start antibiotics and the dosing doesn't really matter, but there actually are opportunities to optimize dosing when you think about antibiotics. All right, the next discussion will be around systemic steroids. So there's 2 studies that I was hoping to review with everybody. The first one is a study led by Dr. Chelsea Davis and her team, and they performed a retrospective cohort study that utilized the CF Foundation Patient Registry Pediatric Health Information System linked dataset, or the CFFPR FIS linked dataset. And this dataset includes relevant outpatient demographic and clinical characteristics from the CF Foundation, and then relevant in-hospital data, including medications from FIS. This was a study of more than 3,400 children with CF who contributed close to 10,000 pulmonary exacerbations. And then among these, you can see that systemic steroids were used in 15% of all exacerbations. So this figure, to orient you, on the y-axis is the proportion of pulmonary exacerbations with systemic steroids. And then on the x-axis are the number of hospitals that participated in the study. And you can see the dark gray line is meant to show you the frequency of early steroid utilization, which was defined as days 0 to 6. And then the lighter gray bar are the later steroids, which were days 7 and more. So what did Dr. Davis find? So these are forest plots illustrating her results. And you can see the higher of the 2 estimates with the confidence intervals illustrates a comparison between people with CF who received steroids anytime during the hospitalization to those who did not, while the bottom plot is comparing people with CF who received early steroids only within those first 6 days. And again, we're compared to people who did not receive steroids at all. So as you can see, a higher pre to post pulmonary exacerbation lung function change and a higher odds of returning to greater than or equal to 90% of baseline function, but baseline lung function was not seen between people with CF who received steroids anytime during the hospital stay versus those who did not. However, if you look at the early steroid use, you can actually see that there was a more than 2-point pre to post pulmonary exacerbation improvement in lung function. But I think it's somewhat interesting is that didn't seem to be sustained when you go back to the return to baseline. So there's maybe a transient improvement. And for those of you who are clinicians out here and have tried steroids early on, this was sort of what I was expecting to see is there's maybe this little improvement, but that perhaps it doesn't seem like it is sustained. And then to add to that, what's a little bit concerning is that Dr. Davis looked at side effects and more specifically insulin use during pulmonary exacerbation as a marker for hyperglycemia. And she found a more than 3 times higher odds of insulin administration among people with CF who received steroids. And this result was found in people with CF who did not have CF-related diabetes, as well as people with CF with impaired glucose tolerance. So I think her study highlights, maybe some transient benefits of early steroid use, but also some really important complications and things to look out for. So the second study, I once again cheated because this is actually not published yet, but I had a chance to talk with Dr. Valerie Waters about her PIPE study, which is really just a phenomenal randomized controlled trial, and she presented these results earlier this morning. I also want to thank her for providing me with these so I can include a slide at the presentation here today. So her study's aim was to look at the adjunctive prednisone therapy use for people with CF who did not have substantial lung function improvement during the first 7 days of IV antibiotic treatment. At day 7, people were randomized to receive oral prednisone 2 milligrams per kilogram per day divided twice daily or receive placebo. And as you can see here with the figure on the y-axis is lung function, on the x-axis are the various time points with the blue circles corresponding to prednisone and then the orange squares related to the placebo. And you can see that lung function changes did not change over the entire time. And that early steroid, this late adjunctive steroid use was not associated with any improvements in lung function. They also looked at several other secondary outcomes, symptom scores and other things, and there were really no differences at all. So I think this is a study that, in my mind, fairly definitively shows that late steroid use may not be helpful in the treatment of pulmonary exacerbation. And then couple this with Dr. Davis's study with the hyperglycemia, that there may be perhaps some complications related to it as well. So I'm not a huge fan of using steroids during exacerbations, and I think these studies can sort of suggest that maybe they're actually not really very helpful. All right, moving on, we're going to talk about the number of antibiotics to treat Pseudomonas aeruginosa. The standard of care has been 2 IVs based on some really old studies that, to be honest, were very small. There's not a lot of data that really supported that. So there have been studies now that have been sort of trying to break down that wall, that perhaps 2 is not better than 1. So this is a study led by Dr. Van de Vander on behalf of the STOP2 team, and it looked at 751 participants in the STOP2 trial who had a Pseudomonas positive culture in the prior 12 months. And the investigators compared clinical outcomes, more specifically changes in lung function, and then mean symptom scores measured by CRIS, where higher scores are worse than lower scores. And they compared them among people with CF receiving 1, 2, or 3 classes of anti-pseudomonal antibiotics. And as you can see from the figures here, the authors found no significant differences in lung function changes among any of the groups, and similarly no changes in the symptom scores. So these results suggest that perhaps more in terms of classes of anti-pseudomonal antibiotics are not better than just 1. And the results also helped to spur the creation of the STOP 360 aminoglycoside trial. So just for those of you who don't know, this is a study that's actively underway, and it's being conducted to determine if combining an IV aminoglycoside, and more specifically tobramycin, with a beta-lactam is superior to using an IV beta-lactam only for the treatment of Pseudomonas aeruginosa and for pulmonary exacerbation. So this figure really just includes the study design, which I won't get into too much for the sake of time, but the plan really is to compare outcomes between these 2 treatment arms after 14 days of IV antibiotics. So thus far, over the first 6 months or so of the study, we're hitting our enrollment targets. And I just want to say on behalf of the entire STOP 360 team, I want to thank all the people with CF and care centers for participating in the study. And then if you want to learn more about it, Dr. Natalie West is going to be one of the plenary speakers tomorrow afternoon and is going to talk a little bit more about this study. So switching gears to outpatient therapy, this was a study that was led by Dr. D.B. Sanders and Dr. Margaret Rosenfeld, the STOP PEDS trial, and this was just published a couple months ago in the Annals of the American Thoracic Society. And they recently completed a pilot study whose goal was to evaluate the feasibility and acceptability of 2 treatment arms for management of a pulmonary exacerbation in children. So this is for the more milder exacerbations not requiring IV antibiotics. And the 2 arms were this immediate antibiotic arm, which was initiated at randomization, along with increased airway clearance, or a tailored therapy arm, where initially it was just increased airway clearance alone. Then children received oral antibiotics if any of these 4 measures were met. So worsening cough or cough not improving within a week, or improving cough but not completely gone by 2 weeks, or any shortness of breath impacting usual activities or at rest. So these are the results. Remember, it's a pilot study, so there were just a few kids that were in it. Overall, there were 63 children randomized, 30 to the immediate antibiotic arm, and then 33 to the tailored therapy arm. And you can see that among those 33 children who were in the tailored therapy arm, so just the increased airway clearance alone, antibiotics were successfully avoided in 70% of pulmonary exacerbations, which is pretty astounding and perhaps suggests that we may not need to use oral antibiotics all the time for a single outpatient pulmonary exacerbation. These results from the pilot study have spurred the creation of a much larger Stop Peds group or Stop Peds study, which is in the final stages of design and hopefully will be unleashed in early 2024. So stay tuned for that. I guess I should also add to that they looked at as an exploratory outcome of changing CRIS score again, so this is symptom scores, just in the 12 to 18-year-olds in the study. There weren't a lot of them. There's kind of a noisy figure, but essentially you can see that the lines overlap over each other, so there actually didn't seem to be any differences in the symptom scores in this pilot study. Okay, so we're going to switch gears here and look at studies that evaluate antibiotic selection. And this is more specifically looking at antibiotic choice based largely on culture data and the utility of switching up antibiotics during pulmonary exacerbation treatment. I'm a diehard Lord of the Rings fan, so I had to include something here. So as Boromir says, one does not simply know which antibiotic to use. There are so many options, and I think for those of us who do clinical care, it's pretty clear that clinicians across the country and around the world get very creative in how they select antibiotics. So over the next 4 studies that we review in the last few minutes, I hope you will maybe think about opportunities to limit antibiotic exposure for the people with CF that you take care of. So this is the first study I want to show you. This is a study that I was fortunate enough to work on, retrospective cohort study that utilized this CFFPR FIS-linked data set. And people with CF 6 to 21 years were eligible for the study, and more specifically, it was people who consistently culture negative for Pseudomonas. And we split up the cohort into 3 groups. The first group were people with CF who were PA negative in the 12 months prior to pulmonary exacerbation treatment, but PA positive in the 13 to 23 months beforehand, and that's the 1-year PA-free group. The second group were people with CF who were PA negative in the 2 years prior to pulmonary exacerbation treatment, but PA positive in the 24 to 35 months prior. And that's the 2-year PA-free group. And then 3 years PA-free were people who had not cultured Pseudomonas in the 36 months prior to a pulmonary exacerbation. So as you can see from this flow diagram, even in the absence of a positive Pseudomonas culture, the vast majority of people are being treated with anti-Pseudomonal antibiotics. So then we then asked, okay, well, are these people who are being treated with anti-Pseudomonals in this situation, are they having better clinical outcomes than those who are not? So these are the results of our study. These are 2 forest plots illustrating changes in lung function pre to post pulmonary exacerbation, and then the odds of returning to lung function baseline. So as you can see, when compared to people with CF not receiving anti-Pseudomonal antibiotics, there were no statistically significant improvements in pre to post lung function change in any of the 3 IV anti-Pseudomonal antibiotic treatment groups. Now, likewise, the odds of returning to lung function baseline were not higher in any of the IV anti-Pseudomonal groups compared to treatment without antibiotics. So I think these results suggest that including antibiotics effective against Pseudomonas may not provide additional benefit for pulmonary exacerbation treatment among children who are PA negative for at least 1 year, and that you can consider instead antibiotics that target the other respiratory organisms that you see, the staph, the steno, the Achromobacter, et cetera. So this study looked primarily at Pseudomonas, but what about other respiratory organisms that might be present? So this is a study from Anna Fano that sought to describe the number of polymicrobial infections among in-hospital treated pulmonary exacerbations. To orient you to the slide, this is an intersection plot that's trying to illustrate the frequency of each combination of respiratory microorganisms. So the y-axis describes the number of pulmonary exacerbation in the data set, and then the x-axis shows you the various respiratory microorganism combinations. So there were close to 5,000 children with CF included in the study who contributed 28,000 pulmonary exacerbation. And then you can see of these, the vast majority were considered polymicrobial. And then really in this study, what I wanted to point out was that the most common combination of respiratory microorganisms was the presence of Pseudomonas and methicillin-resistant Staph aureus or MRSA, and that's the column that I highlighted right there. So based on these results, we were interested in studying pulmonary exacerbation treatment patterns among people who cultured both of these organisms. So this was a study that, once again, used that same data set that I've referred to a couple other times, and we performed a comparative effectiveness study that compared outcomes among people with CF who cultured MRSA and Pseudomonas. and we sought to determine if the addition of anti-MRSA antibiotics to the standard anti-Pseudomonal antibiotic treatment would be associated with improved clinical outcomes compared to treatment with anti-Pseudomonal antibiotics alone. So this figure is illustrating the proportion of pulmonary exacerbation treated with the anti-MRSA and anti-Pseudomonal antibiotics by the 42 hospitals that participated or contributed data in the study. And as you can see, unsurprisingly, there's substantial variability in treatment patterns, not just between the hospitals, but also within the hospitals. And then among the close to 3,000 pulmonary exacerbations that were included, 78% were treated with both anti-MRSA and anti-Pseudomonal antibiotics. So in terms of results, what we found was that treatment with both anti-MRSA and anti-Pseudomonal antibiotics was not associated with improvements in any of the measured clinical outcomes, including return to lung function baseline or time to next pulmonary exacerbation requiring IV antibiotics. We also looked at a change in pre to post pulmonary exacerbation lung function. That's not included on the slide, but there also, again, was no difference between the two arms. So we concluded that children co-infected with MRSA and Pseudomonas may not benefit from the addition of anti-MRSA antibiotics. And again, I think the results from the study provide an area of opportunity to limit antibiotic exposure, particularly in children and adolescents who are likely to see a lot of antibiotics over their lifetime. Okay, so this is the last study I'm going to show you before we move into the stewardship realm for a couple minutes. I wanted to present this study that evaluated the potential benefit of changing IV antibiotics during pulmonary exacerbation treatment. This is from Dr. Zikic and colleagues from Toronto, and they performed an observational study that sought to characterize the reasons CF providers change antibiotics and then to look at whether changing antibiotics would be associated with improved clinical outcomes. So as you can see from this table, the most common reasons cited for changing antibiotics, this was based on a chart review, were changing the antibiotic route prior to discharge, poor recovery of lung function during the initial treatment, and then also drug reactions. So this figure illustrates the changes in lung function from baseline at the beginning of pulmonary exacerbation, during treatment, and then after treatment. And as you can see, there were no differences in lung function changes between people with CF who had their antibiotics changed and people with CF who had no antibiotic changed. So I think, and these studies, of course, and I probably should have said this at the beginning, most of these studies I presented are observational in nature, and ultimately randomized trials are what are needed, but these studies are all suggesting opportunities to limit antibiotics. And I think rather than the more is better sort of modality, we can perhaps be a little bit more thoughtful and judicious in the way that we do things. So for the last 2 minutes and 30 seconds, I'm gonna push my agenda a little bit on antimicrobial stewardship in CF. And I would just point you to this excellent review by Dr. Lloyd from the University of Michigan. She's an infectious disease doctor, and Dr. Saman as well participated in this. And this is a great review that I think provides practical steps that we can all take to incorporate antimicrobial stewardship principles into CF clinical care. So this table shows some strategy examples along with what to do to potentially implement them and then the potential benefits. So for example, requiring pre-approval from either a clinical pharmacist or infectious disease consult before administering various broad-spectrum antibiotics can aid in determining the appropriate agent dose and frequency and help to avoid redundant antibiotics. I've been told at multiple places that I've trained that the pulmonologists are the only ones allowed to use any antibiotic they want. I'm not so sure that's the right idea anymore, so something to consider. Other strategies include developing local clinical guidelines or pathways to improve standardization within your institution. So we worked with our stewardship team to come up with an inpatient empiric antibiotic selection algorithm to try to standardize some of these things. So something to think about. So in summary, optimal duration of the IV antibiotic treatment for many people with CF is likely 10 to 14 days. Data from a recent observational study, as well as this small randomized trial by Dr. Waters and the folks in Canada, indicate that steroid use for pulmonary exacerbation treatment might not improve outcomes. 2 randomized control trials are underway. The STOP 360 AG study, which is comparing 2 versus 1 IV anti-Pseudomonal antibiotic, and then the STOP PED study to determine if a tailored approach to outpatient pulmonary exacerbation treatment in children is effective. And then in my opinion, admittedly a humble opinion, opportunities exist to limit antibiotic exposure in people with CF. Just want to thank the workshop chairs very much for the opportunity to present along with many of my colleagues and some funding sources. And I'm happy to take any questions. Thank you.
Thanks so much, Dr. Kogan. Okay. There were several questions about the steroid use. So in the first study that showed improvement in FEV1 with early steroid use, was there any control for the asthma phenotype like was done in the PIPE study?
Oh man. Chelsea, are you here? I recall that we tried to use the asthma variable in the registry, but it's not a very accurate variable. So I think we either stratified the analysis, or we may actually have even excluded people who had the asthma diagnosis. So it's a fair point. Yeah, in the PIPE study, they excluded people with asthma as well. I should have said too, I wanted to include more about the more definitive trial. There was another really, really small study by Mark Dovey from Seattle Children's back in the mid-2000s, and they actually randomized 12 people to early steroids versus not, and again, did not find any differences. That wasn't in the 12 to 18 months, so we didn't review it per se, but that study in conjunction with Dr. Davis's, and I think Dr. Waters' study, starting to show some convincing data there.
Thank you. And then the other question about the steroid study was, do you know if symptomatic improvement was explored at all, such as more rapid improvement in cough or dyspnea with steroids?
Yeah, that's a great question. Due to the nature of the observational data and the registry analyses and the administrative data set that we use, we weren't able to measure that. But that's, I think, a really excellent question. I will say in Dr. Waters' study, they did look at symptoms, and there were no significant differences in the two arms.
Oh, okay, great.
Hi, John Dickinson from Nebraska. Great talk. In the non-CF bronchiectasis group, there's this idea of the phenotyping, the subsets, and looking at eosinophil levels and IgE levels to help subtype those that may benefit from steroids. That might be something to consider in the future.
Yeah, thanks for bringing that up. So I think the question was mainly about subsetting various people to various phenotypes to see if they could respond more to one treatment or other, and more specifically to sputum eosinophils for the use of steroids. And I think I actually went to Dr. Waters' talk this morning, and someone asked her that question. She and her group have that data and are going to maybe look at that to see if the people that did respond in their study to steroids had more sputum eosinophils compared to others. So I think that's an interesting question. And a lot of these questions are not getting at the subsets. And whenever we publish any of these papers, the reviewers always say, what about this group and what about that group? And they're all fair questions and fair points, but it's hard in these big registry observational data sets to really subtype down. You're going to go down and down and down. You can't really do that in randomized trials either, right? You have to kind of at some point cut yourself off. So I think it's a really good question, and I think it's undeniable that some people will respond to steroids. Just in the sort of overall population level thing, there just doesn't seem to be good evidence for it at the time.
Okay, great. What percentage of patients were on ETI in the anti-Pseudomonas study, and do they account for nebulized antibiotics?
Yeah, so this is the 1 year PA-free, that study, right? Yeah, so it was done pretty much before ETI. So there were actually even small numbers of people on ivacaftor, something like 3 or 4%. Yeah. So there wasn't a lot with respect to modulators. And then in terms of the inhaled antibiotics, we did adjust for those in the analysis. And I will also say there's also growing literature that has not been published in the last 12 to 18 months, but there's growing literature that seems to suggest that the use of inhaled antibiotics for pulmonary exacerbations is also not associated with improved outcomes. So that may not make much of a difference. Another opportunity to limit antibiotic exposure, perhaps.
Kind of two related questions. Like, one was about how does likely improved life expectancy in CF impact your thinking about antibiotic stewardship? And another question was about now that FEV1 is a conventional outcome, but relatively crude with more people, do we need to look at other outcomes?
Yeah, so the first point I think is just an excellent point. A lot of data around antibiotic exposure is related to cumulative antibiotic exposure and associations with things like ototoxicity and nephrotoxicity, not to mention antibiotic resistance. Whether you believe in that or not in CF is a whole other story. So I think cumulative exposure absolutely matters, and if you can avoid a course here and there, that really does make a difference in my opinion. And then the second question was mainly about using lung function as an outcome for these studies. Yeah, it's tough, and I know seeing other talks this morning about z-scores rather than percent predicted might be ways to do it. We talked a lot about the race-neutral equations and opportunities around that, but I think we're going to be stuck with lung function for a while, at least in observational studies, though I think in randomized trials there's opportunities to focus more on symptoms and other quality of life measures.
Okay, just one more. I guess based on the study presented, how far back should you consider covering for Pseudomonas growth in previous cultures during an acute pulmonary exacerbation?
Yeah, so this is totally my opinion, you guys, but I think you can be pretty confident that 2 years, I really would consider not using IV anti-pseudomonals. Now, there's lots of caveats to this because we know the culturing is all over the place. So using a OP swab is not necessarily indicative of what happens in the lower airways. But that's what we looked at. We were using real life and real world culture results for the study. So I think 2 years, and I will push my colleagues at our institution to consider 1 year. And I think some people feel pretty comfortable with that.
Great, thank you so much. Okay, our third talk is Dr. Tanya Gonska, and she's a staff gastroenterologist and associate professor in the Department of Pediatrics at the University of Toronto. And she also has a subspecialty focus on pediatric pancreas diseases and cystic fibrosis. She's also a senior associate scientist at the Research Institute of the Hospital for Sick Children. Additionally, she is the PI of the Canadian CF Newborn Screening Study, and her main research is focused on forwarding our understanding in transepithelial ion and fluid transport in the airway and intestine. And today she's going to talk on advances in diagnosis and management of GI manifestations of CF.
Okay, good afternoon, everybody. Thank you very much for this. Sorry for the difficult introduction. Thank you for the chair and the NACFC for inviting me to talk. So I have no disclosure on the slides. But since I'm talking in Phoenix and currently the World Series going on in the baseball stadium, I want to give a shout out to my husband, Brad Lueger, who engineered in 1998 the rooftop, the retractable. So I use this opportunity, and it's filmed. So back to GI. So I was tasked with not only talk about GI, intestinal disease, but then somebody put liver on that too. So I give my best. Last year, this was presented here at the North American CF conference, and this year published in the Journal of Cystic Fibrosis. Some of the CF digestees formed Galaxy, which was a multi-center study to develop electronic patient-reported outcome measures to really better assess GI symptoms. And they did quite some extended work in that, and this is published some of here, and they found that most of the symptoms reported was stomach fullness, bloating, straining, incomplete bowel movement. They also found that the highest score when people rated their symptoms was in abdominal pain, and 20% actually reported about moderate to severe GI symptoms. So in a back-to-back publication, they used these electronic patient-reported outcome measures to then look if ETI had an effect on GI symptoms. And though they did see some improvement, the author rated them as clinically insignificant. Nevertheless, there was a reduction in the number of patients reporting moderate to severe GI symptoms, such as abdominal pain, early satiety, nausea, but not stool symptoms. So this shows that the job for the GI physicians, GI researchers, and dietitian is not over yet. So intestinal disease and CF. So to better diagnose and treat GI diseases in CF, we need first to invest a little bit more in detailed understanding of the pathology. And there's been great innovation and contribution over the last year. I thank Keith Oy for letting me use a schematic here. And just to remember you about the CF gut concept that we use in our daily management of GI symptoms. The CFTR defect here on the intestinal apical membrane needing to transport chloride and bicarbonate, so the defect changes the mucus to be viscous, acidic, thick, and that in sequelae changes the microbiome to form like a dysbiosis. In association and consequence, there's also then intestinal inflammation and dysmotility. And we think that to some degree, at least, there's an association to the abdominal symptoms that our patient report. And we do in clinic now use that concept to address all these single items that we believe happens in the CF gut and to throw antibiotics or probiotics to manage dysbiosis, polyethylene glycol to get rid of that thick mucus. We are still kind of struggling to really target inflammation in this debate. And we have introduced prokinetics, constipation management, targeting the dysmotility. So in the first study I want to present here in a very summarized form, it shows that the polyethylene glycol concept may not be that wrong. It's a study coming out of Holland who has done a lot of work on looking at bile and bile losses. And here just to strike is bile is important for efficient absorption of fat and cholesterol and fat-soluble vitamins. And CF patients they found have an increased loss of bile. So here they did a nice mouse study using delta F508 homozygote mice. And for 2 weeks, they fed PEG to one group of mice and placebo in the other. And then they realized and they measured that PEG, those with PEG, the bile acid absorption was normalized. And secondary, that affected also the fatty acid and cholesterol absorption. And by more detailed study, they showed it was not because of increased bile secretion or improved transport of bile acid across the intestinal membrane, but actually by just having it better emulsified, better soluble, and there at the transporter. They also looked at genetic difference between these mice, and they found that 867 genes were normalized in these PEG-treated mice that involved bile acid and cholesterol metabolism. They looked at the liver, found an effect on peribile duct inflammation, but not on proliferation fibrosis. There's been a lot of publication and look into the dysbiosis in the CF microbiome, intestinal microbiome. So just for those who are not so familiar with these terms, alpha diversity in the microbiome analysis looks at the distribution of species abundances in one sample, so how diverse that one sample is, and the beta diversity looks at dissimilarity or dissimilarity between two samples. So in this study, people looked at the development of intestinal microbiome in cystic fibrosis in early life. There are 39 CF children aged 0 to 4 years, and they were using 16S RNA gene amplicon sequencing of the stool samples. They saw that over the first 0 to 2 years of life, there's an increase in the diversity. More diverse is better. And that happened early on, and then it was no more. There was no more increase. And the main kind of dissimilar of that stool sample happened very early when it was forming under the age of 1 year. Increasing over age, they found that was the bacterial taxa shifted to more a healthy-like microbiome over age, except for a couple of bacteria, like Bacteroides, Prevotella, Akkermansia, Bifidobacterium, and Bloschia. They found also some lung pathogens in stool sample, and there's the whole concept of whether they are seeding from the oropharynx early on before they even become apparent in the lung. And they found Haemophilus, Prevotella, Staphylococcus, and Veillonella. The bonus study already showed that, this is the newborn screening study in the US, already showed that there is an association between dysbiosis in children and growth. And here, in comparison between US infants and Australian infants, they found that the Australian infants had a higher weight for HZ score than the US children. But the Australian children received antibiotic prophylaxis, but the US children did not. They also looked at the difference in the microbiome, and they found that the US children had a more similar microbiome compared to the healthy controlled children, and the children from Australia were more dissimilar. Dysbiosis may have long-term sequelae, and colorectal cancer is a great risk of disease in CF. And here this study wanted to see whether those people for whom adenomas were detected had a difference in their microbiome, or where they were going at with short-chain fatty acid than those without adenomas. They looked at adults undergoing screening colonoscopies for colorectal cancer, and they had 21 CF, and they matched it with 21 non-CF patients. They found no difference in short-chain fatty acid levels in the CF group compared to the non-CF people, though there was a reduced level of branched fatty acids. Nevertheless, there was a difference found in the taxa of bacteria in those CF patients with adenomas, and particularly one bacterial group here, Bacteroides fragilis, was standing out. A strong message comes from down under Sydney with Dr. Oi's publication showing that you are what you eat. And diet as being a really contributor to dysbiosis. This study was part of a larger health study in Australia. Sorry, I screwed up. And they were looking at 41 CF patients matched with 41 healthy control. And they had 19 in each group who have completed all the elements. And what they saw here, like in this graph, that CF had a higher energy intake diet compared to the healthy control, and that mainly consisted of fat rather than carbohydrates. And when they also measured intestinal inflammation using fecal calprotectin, and they found a positive correlation between the fecal calprotectin levels in these patients to the intake of takeaway food, and a negative correlation to the intake of whole grain. The caveat of this study was a 6-month recall of diet, so there's maybe accuracy, but it's a nice already association. They also did more analysis and they found correlation between diet and enrichment of certain GI bacteria, and specifically they focused on Akkermansia. It's a mucus degrading bacteria, and they found a negative correlation between fecal calprotectin and Akkermansia, and they even correlated back then to a positive FEV1. Probiotics so far have not found their way in clinical use. A Cochrane review from Dr. Oi showed that there was no effect, the studies published so far, on any pulmonary disease. Nevertheless, 2 studies found an effect on fecal calprotectin, intestinal inflammation, and, sorry, I missed this. And another study coming out of Israel looked at probiotics and their effect on glucose metabolism and suggested there was a change in that profile, so not very significant yet. Also, they found that there was an improvement in questionnaires and the digestive domain, but that went back to baseline after 4 months. How about the CFTR modulators? Tezacaftor, ivacaftor had no effect on the microbiome. There's one study that is not yet peer-reviewed. It's an NIH project to already published that before. And they found in children, a change of alpha diversity with ETI. And they listed some bacteria that changed in those patients on ETI. They also calculated the microbial dysbiosis index, which has been developed for Crohn's patient, and it showed also that this is reduced in those on ETI. So now to come to liver disease and CF. There was always a worry how to identify in clinic patients who then not only have increased ALT, AST, and some change in ultrasound, but how to identify those who then progress to liver disease. This is a very elegant study by Dr. Long and team. It was a retrospective study, 2 centers, and they identified patients for whom they also had biopsies and liver explants. They classified then, when they had the biopsy or explants, the fibrosis by a severity score, 0 to 2 not so severe, 3 to 4 more severe, and patients were at baseline 7.5 and 10.5 at the biopsy age. And they found that those with the later stage, a more severe fibrosis stage, a change occurred usually in 3.5 years, but faster in those who at baseline had a lower FEV1 and Pseudomonas colonization when they were young. Interestingly, they also found that desoxycholic acid did not protect from this progression to fibrosis, and in their sample, severe fibrosis did not occur in any participant that were not on URSO. The early progression to this higher fibrosis score was found to be associated with a lower platelet count, higher AST levels, and a higher GGT to platelet ratio. And then they came up with a model which they showed a good area on the receiver operator curve where they put together ratios of AST to platelet, GGT to platelet, and a fibrosis score to predict who will progress to fibrosis. Next to severe liver cirrhosis with portal hypertension is now a new liver disease entity in CF, which has been reported before, nicely here in one retrospective center in Italy. Portosinusoidal vascular disease includes these non-cirrhotic hypertension and commonly found in CF liver explants. And this center looked at patients and diagnosed portal hypertension, and then they performed liver stiffness measures. And they found that a subset of those where they saw portal hypertension did not meet the criteria for cirrhotic liver disease. And on liver stiffness measurement, they also didn't go in that range, or that high liver stiffness range that people usually see with CF liver disease. So they proclaimed that these patients have portal hypertension in absence of cirrhotic liver. And when they looked at their group, they found that these patients are usually older and have more normal liver enzymes. But when they do a Kaplan-Meier analysis of survival, also these patients have an increased mortality. So for the last bits, to just cite the publication coming out in Direction to ETI and liver disease. And this was a longitudinal effect on liver in ETI patient. It was a single adult center, 255 patients, and they were at least 12 months on ETI. And 30% had a diagnosed liver disease, 31 with portal hypertension or liver transplant. They saw in 24 develop minimal bilirubin increase. 3% had ALT levels more than 3 times upper limit of normal in that period, and 2 with a higher of more than 5 times upper limit of normal. 6 patients had AST more than 3 times upper limit of normal, and none had 5 times upper limit of normal. They usually kept going on ETI and described that levels came down when they looked at alcohol use or medication, food supplements, and stopped those. The author cited that they had to stop ETI, and then they reintroduced it in 2 patients that also had liver biopsies because of the high levels. 1 liver biopsy in 1 patient was normal, and that patient had a very high ALT of 370, and 1 showed periportal inflammation, but no signs of necrosis. The same group actually also then reported outcome on their liver disease markers in patient ETI and showed no change in the degree of severity of liver disease. And they did mention that the liver stiffness measurement, those who had higher measurement at the beginning, was reduced. Another study reported about the incidence of transaminitis in patients on ETI, and had 83 patients in that study, median age 31. Third had CF liver disease, and they saw ALT, AST elevation more than 25 percent of baseline, and 36 they evolved. They saw bilirubin elevation to at least 2 milligrams per deciliter in 3 patients, and they had a couple of patients with really high ALT and AST levels. Their therapy was held in 2 and modified in 2, and they commented that they did not discontinue treatment for any of their patients. So in conclusion, and putting that onto one slide, this year has helped to further understand intestinal disease and liver disease and CF. And when you look at intestinal disease and you include the exocrine pancreas dysfunction, that actually would lead to nutrient failure if we would not work massively against it with enzymes, high-calorie food, vitamin supplementation. But furthermore, we now learn that the dysbiosis, and here Dr. Kogan sorted here the antibiotic use and provided caution, may also impact lung disease and then also liver disease. So I think going forward, I think it's reasonable to also focus on measuring intestinal outcome markers in our patients to address their health status. And such of these measures could be fecal elastase, pancreas imaging, or fecal calprotectin for assessing intestinal inflammation, luminal imaging by endoscopy, making sure that we assess nutritional markers, and maybe in future also using changes in microbiome to see if our patient is gut healthy. So thank you very much.
Thank you, Dr. Gonska. I'm just checking for any questions. So it seems that the 2 talks went together, that maybe increased antimicrobial stewardship might support your theory of the intestinal dysbiosis. Do you want to talk more about that?
Yeah, it turns out, like many of these studies mentioned, and I think I skipped over that a little bit, that they found more dysbiosis in those with antibiotic use. So antibiotic use was significantly contributing to dysbiosis. So, yeah.
I want to give you the opportunity to speculate with the effects of ETI, maybe on dysbiosis, intestinal inflammation, digestion, bile acids. Do you want to predict whether this might have a beneficial effect on the frequency of colon cancer or GI cancers?
Yeah, so in this one study, they were looking for that, right? And I think they saw this association or the difference, I don't know, in the microbiome in those with polyps and those without. And there's been a discussion, right, whether intestinal inflammation, dysbiosis would be the etiology, the cause, or the driver for colorectal cancer. We just showed and presented this morning in our cohort in Toronto, intestinal inflammation did not associate with polyps. But it doesn't mean that if you have a dysbiosis, that you necessarily also have intestinal inflammation. There may also be great overlap and variability.
There's a question at the microphone.
Terrific talk. Thank you so much. So just wanted to make sure that I was understanding that there were 2 things that we were found to decrease calprotectin and therefore inflammation, and that was use of Miralax and probiotics. Is that correct?
So fecal calprotectin
and therefore likely inflammation.
Is reduced by polyethylene glycol?
Yes, sorry, polyethylene glycol is Miralax, yes. Sorry.
So the study did not look at fecal calprotectin, it looked at bile acid, right? So they did not measure fecal calprotectin. So that relation between fecal calprotectin and polyethylene glycol use, I have not seen a study, but I may have missed it.
And in terms of the probiotics, you know, there's such a wide range of what's considered probiotic use. Was there specific probiotics that were used, a specific species, or uncertain?
Yeah, in the Israeli study, they used different strains of lactobacillus and bifidobacterium.
Thank you.
I was a little surprised that the GI symptoms didn't improve more quickly or to a greater extent with ETI. Do you have a sense of why that might be when the lung gets so much better, the sinuses, yet we're seeing the symptoms change relatively little? Is it different mechanism that's causing them? Why aren't they getting better?
why they are not getting better. So this is to the PROMISE group, right, to look at that. We also had in our presentation, we didn't do it longitudinal, we had cross-sectional in adults, abdominal pain symptoms were as experienced in those on Trikafta as those not on Trikafta. So the question is that only like a timing effect? Do we need more time in order to, change our microbiome? Or is diet maybe driving more severely that dysbiosis, and the dysbiosis is now running its own course? So I think this is really good kind of food for future research and looking more closely into that. So I can't answer why that is.
And there's one more question at the microphone, I believe. No? I guess not. So, not seeing any other questions. Thank you. Very nice.
Thank you.
Very nice. And now I'd like to introduce Julie Gilmore. She's an assistant professor and attending physician in the endocrinology division in the Department of Medicine, University of Toronto, and she's based at St. Michael's Hospital. She's been active in particularly diabetes related to cystic fibrosis and a special interest on screening. And given all the changes that are going on with the effects of body mass index, et cetera, with the use of modulators, I think this whole area is undergoing change, and I think we're very interested to hear what we can learn.
Okay, thanks for having me. It's hard to be the last one after all those amazing presentations, especially as a lowly endocrinologist, but I will try my best. I have no disclosures for this presentation today. So as you heard, I'm an endocrinologist in Toronto, which I think is a very special research place for both diabetes with the discovery of insulin and for CF with part of the discovery for the CFTR gene. And I work at a tertiary care hospital, St. Michael's Hospital, which is an adult CF clinic that serves about 500 patients with CF, and about 35 to 40% of them have CF-related diabetes. So although I see many patients with CFRD, for a general endocrinologist, cystic fibrosis-related diabetes is actually quite rare. The list on the right shows many different types of diabetes, and for us endocrinologists, we see the majority of type 2 diabetes, followed by type 1, and if we're lucky, we might see a few patients with some of the more rare types of diabetes, for which diseases of the exocrine pancreas falls and cystic fibrosis-related diabetes would be considered one of those types. For us, it's a unique type of diabetes. It has overlap features between both type 1 and type 2 diabetes. And if you recall, type 1 diabetes is an autoimmune disease causing destruction of the pancreatic beta cell, whereas type 2 diabetes starts off as an insulin resistance. On the flip side, for you as CF physicians, it's the most common extrapulmonary manifestation of the condition, and it increases by age. So by age 40, more than 50% of people with CF will have this condition. So for this year in review, I thought I would talk about 3 important themes over the last 12 to 18 months. The first, screening and diagnosis. The second, technology in CFRD. And then end off with the effects of ETI on glucose metabolism. So let's start off with screening. So we all know that the gold standard test has been the 75-gram oral glucose tolerance test. However, it is not without limitations. It's a major burden to our patients with CF. It requires fasting, a 2-hour time requirement, and many patients report feeling unwell with the glucose load. In addition, the thresholds that were developed were based on the risk of developing retinopathy, so a microvascular complication in type 2 diabetes, and they're not specific to CF. In addition, we know that between 2 tests, we can see variable results in different diagnostic categories, which leads to some inconsistencies in the diagnosis. In clinical practice, we see low screening rates, and this is especially common in the adult population, with reports from the literature saying about 25 to 48% of patients are screened annually. So there is heterogeneity in terms of the uptake of this test. So I thought I would highlight a couple of surveys, studies that have been done over the past year looking at CFRD screening. And the first is this American paper which surveyed 51 centers and 25 endocrinologists and found alternate screening strategies were being commonly used in clinical practice. The most common alternative being the A1C. 64% of CF clinics said that they use this test, and 92% of endocrinologists. So why is A1C being used in clinical practice? Well, it's a simple and widely available test. It doesn't require fasting, but the concern in CF has always been about underestimation of the glycemic control due to this accelerated RBC turnover. So there's this concern that some people with a quote unquote normal A1C will actually have an oral glucose tolerance test that's diagnostic of the condition. However, recent literature has shown that a lower threshold, perhaps between 5.5 or 5.8%, could have a high sensitivity to rule out the condition, and maybe a stepwise screening protocol could be used. So I'm going to give you a sneak peek at our upcoming Canadian guidelines, which are actually going to promote a two-step screening algorithm, starting with A1C and using the 75-gram oral glucose tolerance test in some people. And this approach should actually reduce the number of oral glucose tolerance tests in our practices by at least 30%, which is significant for our patients. And the second paper I wanted to highlight for the section is a survey that was done in France, which looked at 47 centers. And the interesting thing here is that although oral glucose tolerance test was the most commonly used screening tool, CGM, or continuous glucose monitoring, was actually the second most common, and quite closely with oral glucose tolerance testing. 69% of centers reported using it after an oral glucose tolerance test, and 31% as a primary screening tool on an annual basis at home. So continuous glucose monitoring is a technology that's used to measure interstitial glucose. It's actually not approved as a diagnostic test in any type of diabetes, and there's really no consensus on which CGM parameter or threshold should be used for diagnosis in CF. Some studies, however, have shown a correlation between hyperglycemia on the CGM and poor pulmonary and nutritional status. And so I think that leads really nicely into this second section about technology and CF-related diabetes. So I wanted to start off highlighting this systematic review and meta-analysis that was published last year, which looked at studies comparing CGM to glucometer checking with finger pricks in patients with CFRD. The primary outcome was the mean difference in the plasma A1C. Before I go through the results of that paper, I want to highlight a little bit about continuous glucose monitoring in diabetes in general. I think that there's a few key points. Firstly, there are two types of systems available for this: a real-time CGM and an intermittently scanned CGM, which is a flash monitor. In type 1 and type 2 diabetes, we know that the use of technology with CGM reduces A1C by about 0.2 to 0.4% in meta-analyses. And in type 1 diabetes, we know that this technology can lead to improved quality of life outcomes, especially hypoglycemic distress. So as an endocrinologist, when we look at CGM metrics, we're looking at 5 main things typically. We're looking at the percent of time the patient is wearing the sensor, and we're looking at time in ranges. This is an example of what one of our sheets might look like. You can see that we look at the time in the target range between 4 and 10 millimoles per liter, as well as the amount of time spent above and the amount of time spent in the hypoglycemic range. The third thing that we look at is the coefficient of variation. So this is the variability in glycemic control over a day. And we know that less variability is associated with less hypoglycemia in type 1 diabetes. And then we look at the ambulatory glucose profile, which I'll show you in a later slide, as well as daily logs for the patients. In type 1 diabetes, we know time in the target range is well correlated with A1C, as well as microvascular complications. So what do we know about CGM and CFRD? Well, we know actually that the usage of this technology is actually quite high. Some studies reporting as many as 75% of patients using it, though there's little evidence to support pulmonary-specific outcome targets with the CGM data. Though we know that blood glucose levels greater than 7.8 are associated with impaired function of airway surface liquid layer, and that insulin treatment for CGM blood glucose levels greater than 7.8 more than 4.5% of the time improve FEV1 and weight in CF-related diabetes. So I think one of the future directions of research really needs to be focused on, should our targets be adjusted when we're looking at these parameters in our patients, sort of like we do in pregnant patients with diabetes. So back to this paper. So none of the studies in this meta-analysis compared CGM with glucometer directly. But as you can see, all of the means here fall to the left side of unity, with the overall weighted mean difference favoring CGM. Although this study has some limitations with heterogeneity and publication bias, I think the interesting thing is the percent reduction in A1C we see is 0.4%, which is actually similar to what we see in the type 1 and type 2 diabetes literature. So I now like to move on to this second paper, which is a retrospective multi-center study that included 13 patients with cystic fibrosis-related diabetes. They had 14 days of CGM data analyzed at baseline, 1 and 3 months after the use of a hybrid closed-loop system. And the primary outcome was the percent of time patients spent in that target range of 4 to 10 millimoles per liter. So what is a hybrid closed-loop system? It's also, the artificial pancreas. It was FDA approved in 2019, and it's a hybrid because only the basal insulin is actually a part of a closed-loop system. So here you can see on this patient's abdomen on the right-hand side, the continuous glucose sensor. It communicates with a control algorithm, which that connects to the pump and adjusts the basal rate of insulin being provided. The bolus insulin has to be given separately through the pump by the patient and isn't part of this closed-loop system. So what do we know about hybrid closed-loop systems in type 1 diabetes? Well, we can see from this meta-analysis that comparing standard of care to hybrid closed-loop system, the studies really here all fall to the right of unity, which favors the hybrid system. And on average, time in the target range improves about 12% with the use of this type of technology, bringing the time in the target range up to about 71%, which, if you remember, might roughly correlate with an A1C of 7%. This type of technology is actually also associated with improvements in quality of life parameters, including fear of hypoglycemia and less treatment burden, so time off. In order to use a hybrid closed-loop system, patients need to be using an insulin pump, and we know from the literature that generally the rates of insulin pump usage are low, some studies reporting between 4 and 29% use. There's multiple possible contributors, including cost concerns, irritation at the site, and embarrassment over wearing the device. In this study, 61% of the cohort actually was already wearing an insulin pump at the time of starting the study. The mean age of patients was 38, and the mean A1C was 8.7%. So if I can draw you to the graph on the right-hand side, you can see on the x-axis the time on the control IQ algorithm, and then on the y-axis the percent of time in the target range. And the percent of time in the target range increased by 15% from baseline after using the system, which is similar, if you recall, to what I had mentioned about the type 1 and type 2 diabetes population. So here you can see the time in range improved from about 54% to 69%. And the really amazing thing is this didn't come at the expense of significantly increased hypoglycemia. It was unchanged. This is an example of an ambulatory glucose profile. So this is what we look at commonly when we evaluate sensor use. In the blue line there, you can see the patients at baseline, and then a nice shift down at the 3-month mark after starting to use this technology. And so I think this study really builds on the literature in type 1 diabetes, and it confirms the safety and effectiveness in CFRD, which is a unique type of diabetes to type 1 diabetes, in that there's more endogenous insulin production in comparison. So finally, I'm going to move on to the effects of ETI on glucose metabolism. So this summer, this meta-analysis, the systematic review was published, and it included people with and without CFRD and examined the effects of ETI on any measure of blood glucose. This was adults as well as the pediatric population. And so you were able to be included in the study if there was a fasting blood glucose evaluated or a glucose tolerance test, A1C or CGM data. And so 13 articles were included in the final synthesis. All were observational studies comparing pre and post ETI initiation. They were generally small studies. The mean sample size was around 11, and with fairly short follow-up, just at about a year for most. What's amazing is that 8 out of the 11 studies reported an improvement in at least one measure of blood glucose metabolism. This is a summary figure of the OGTT data from the study. Although the arrows are a little bit overwhelming, I wanted to highlight a few things. So the number of people with normal glucose tolerance increased after ETI use from 30 to 45, and the number of patients with CFRD actually also improved from 10 to 3. Though with all the arrows, it's important to note that there were actually patients moving between categories. So for example, the 3 of the patients with CFRD at the end, one of them started off in the IGT group and one started off in the indeterminate group and ended up in that category. So there does appear to be some heterogeneity in terms of the effect of ETI on glucose metabolism. No study showed a significantly increase in the measures of hypoglycemia. So the effects of ETI on glucose control have been really a hot topic in CF endocrine research recently with an explosion of papers in the area. And so I thought I'd finish off by highlighting a few of the papers from the systematic review, as well as this paper actually that was published after, which uses a different study design in that it's a case control study looking at patients with CF and pancreatic insufficiency. 3 patients at baseline had cystic fibrosis related diabetes. Only 1 was on a very small amount of insulin. And they looked at beta cell function over 2 visits. So at baseline and then restudied post ETI or the control group. And what they found is that oral glucose tolerance category improved in 44% of the patients on ETI and only 14% of the control group. They also found here that ETI was associated with an improvement in A1C, which is statistically significant from about 5.8% to 5.4% in the ETI group. And what's really interesting to us endocrinologists is it looks like the initial secretion of insulin from the beta cell may be improved. So if you look at the figure at the top left, this shows a normal insulin response to food with a rapid burst of insulin followed by a slower second phase release. In CF, we know that the first phase is often impaired. Now, what they found in the figure at the bottom right shows that the insulin secretory rate on the y-axis and then over time after a mixed meal on the x-axis, what you'll see is a much steeper curve in the group following ETI therapy compared to the group at baseline, whereas with the controls, there was no change over time. So the second paper I wanted to highlight is this one out of Belgium. We looked at patients with a much longer, more established diabetes, all on insulin with a mean duration of diabetes for 15 years. And what they found was that there was a reduction in insulin requirements in 88% of the patients. So despite their weight and BMI increasing, their total daily dose of insulin actually decreased. And this was statistically significant from 50 units at baseline to 44 units post. And there was a trend toward improved A1C as well. And finally, I want to highlight this study. So this was of 33 adult patients, evaluating them 3 months post-ETI. They looked at oral glucose tolerance test results as well as insulin measurements. Baseline glucose status was variable, so it included people with and without CFRD, but all were insulin treatment naive. And what they found is that around 50% of patients improved their glucose tolerance category. The figure on the right-hand side shows the OGTT over minutes and then the glucose level on the y-axis. And you can see that there was a statistically significant improvement in the blood sugar value at the 2-hour mark on the OGTT, and also an improvement in A1C that was maybe less clinically significant, but definitely statistically significant. The insulin and C-peptide level, however, did not increase, which is a little bit contradictory to the first study that I mentioned, as this suggests that perhaps it's not a preliminary beta cell matter that gets better. So as I mentioned at the start, we know that the fundamental pathophysiologic mechanisms of CFRD is islet loss and fibrosis. But there are other likely contributing factors, which I think are laid out really nicely in this figure, and understanding the mechanism by which ETI improves glycemic control in CFRD is in its early days, and I think it's a really exciting time to be in this space. So it may be due to an improvement in insulin sensitivity with less chronic inflammation. There may be increased glucose consumption, which could be a result of increased physical activity. And there's also the tantalizing probability that the beta cell function might be improved. So with that, I hope you will take home from this talk that CFRD is a rare and unique type of diabetes. Screening for CFRD has its challenges. There's some heterogeneity in practice patterns, and alternate screening protocols have been proposed. Diabetes technologies can positively impact glycemic parameters in people with CFRD. Future research is needed to understand the connection between glucose metrics and disease-specific complications, specifically pulmonary and nutritional, and also to explore the impact of quality of life in CFRD. And ETI has a mostly positive impact on glycemic control. Glucose levels should be very closely followed after these therapies are initiated. And the mechanism of impact is incompletely understood and still requires further research, and I think might teach us more about the pathogenesis of CFRD. So with that, I can take any questions, and I'm happy to correspond via email. And I want to thank everyone in the CF clinic at St. Michael's Hospital, both the patients and the providers, for allowing me the opportunity to learn from them over the last decade.
I don't see anyone at the microphone. I'd like to ask you, it's been discouraging that we're not able to use hemoglobin A1C as the global screening test because of its lack of sensitivity, and it's been blamed on shortened red cell survival. There may be other things as well. Is anyone looking to see now with ETI, whether that's affecting red blood cell survival time and whether or not we might be able to rely even more on hemoglobin A1C than we have been?
That's a great question. I don't know if anyone's doing any specific research on that, but my feeling on it is that I agree with you. I think as the CF population is more well generally, I think that we will start to be able to rely on this test that we use in other types of diabetes quite well. I think one of the nice things is that we know A1C correlates very nicely in type 1, type 2 diabetes with CGM parameters. And so using both together, I think it might not be a matter of one or the other, but using a bunch of these tests together for our specific patients.
I'm not sure if you can speculate. Also, are the changes, I'm just thinking about in children, selfishly being pediatric, but are some of the, when ETI extends down, is there any research saying that will improve the mechanisms and prevent diabetes? More of the primary prevention kind of tactic?
Yeah, so I think, there's been some population studies in the UK looking at post-ivacaftor therapy and seeing lower rates of CFRD, so that might get at that a little bit. I think, these medications been used in pediatrics and seeing patients come off insulin in their entirety. Unfortunately, I didn't have time to present one of the recent papers, but I think that there's a potential there'll be less pancreatic fibrosis, and so more beta cell reserves potentially, though on the flip side, potentially more insulin resistance with people at heavier weights and that sort of thing.
There was a question, what non-insulin therapy should we be considering in people with CFRD who have endogenous insulin production based on positive C-peptide levels?
So I don't think there's any literature, saying that one specific insulin regimen is better than another. C-peptide levels can be helpful, and there's a little bit of literature looking at it with LADA, so that's a different type of diabetes, and stratifying patients as to how much endogenous insulin function they have. And so I think it's a really unique idea to be using that potentially in our CF patients, so I don't think there's a lot of literature there. For us in our clinic, we look at people's ambulatory glucose profiles and try to target whether they're having postprandial hyperglycemia or fasting hyperglycemia and pick the regimen really based on that.
One more question. What is the A1C cutoff that the new Canadian algorithm will use? I think it's set on the flow chart. 6.4.
Yeah, so the algorithm is going to basically say between 5.5 and 6.5, you do the oral glucose tolerance test. If it's less or greater than that, like if it's greater than that, you've made the diagnosis anyways, because we're worried about a false low. And then if it's less than that, we're saying it's very unlikely that you have CFRD. There's a high sensitivity based in the pediatric as well as adult population.
With the differences in CF-related diabetes and type 1 in particular with glucagon, when you're talking about bionic pancreas and things like that, does that influence how you would want to set this up?
Yeah, so in type 1 diabetes, and this is one of the mechanisms through which patients are more likely with type 1 diabetes to have diabetic ketoacidosis. They have preservation of their alpha cells, so their glucagon levels are typically higher versus with CF-related diabetes. We see lower glucagon levels. There has been a study, I think it was from 2020, looking at a bionic bihormonal pancreas, which was really promising. So I think that could potentially have a huge role here.
But I believe there is a study going on with a bionic pancreas.
Yeah.
Do you want to just describe it in a little more detail? Are you familiar with that one that's starting up soon, eventually?
The bihormonal one, or the?
Oh, if you're not familiar with it,
Okay.
I shouldn't ask. So.
Yeah, I mean, I think all of them are kind of the bihormonal would be with insulin and glucagon. But please tell us. If I don't know if I know.
No,
Okay. Okay.
So if there are no other questions, we'll just have a few minutes where we'll bring the panel members up here and just have some general questions. You're welcome to text them in or use the microphone. Yeah. So each of you spent time doing a nice year in review of what occurred within the last year or 18 months. And so what I'd like to do, each of you, knowing what's coming down the pike, what people are actively doing now, what are we going to be looking forward to in the next year? So when we're doing the year in review a year from now, what's exciting you that's going to answer questions that you've been wanting to be able to get answers to? John, do you want to start at the end?
Okay, that's a good question. I'm not sure a lot's going to change in the next year for exacerbations.
All right, next person.
Yeah. I think the STOP 360 aminoglycoside study that I was referring to, we're 6 months in. It's a 4-year study because we're trying to randomize literally 400 or 500 people to get the study outcomes. So stay tuned for that one. The STOP PED study is going to probably start in early 2024, and that's going to go for at least a couple years also. I don't know of any other randomized trials that are underway for exacerbations. If anybody else does, please correct me. So I wouldn't expect any dramatic changes based on that.
Yeah, and Jennifer, just pass the microphone down the road.
I think we are actively anticipating more and more data on ETI as well as other triple combination therapies in younger and younger kids, and those studies are obviously ongoing. I do think it will be interesting to see how we're able to focus, particularly with this neuropsychiatric neurocognitive questions, which haven't been as prominent in previous study designs, and also to some extent may run counter to some study designs, right? If we have kids who are potentially going on a study drug in part because the family has seen neuropsychiatric issues on a commercially available drug, our studies aren't usually designed to capture positive effects in that sense, as opposed to capturing adverse effects. And even the AE capturing has been, I think, a little bit challenging when it comes to these vaguer symptoms that may or may not be related to childhood. So hopefully we'll have some better parsing of some of that data and a better understanding of whether there's a class effect, how we might be able to predict these things. That's obviously not just next year, but ongoing.
I think in opposite to Dr. Kogan, I think GI is just waking up, and you see, I think you see it at this conference. I mean, I remember so many airway and physiology that I went to, and now it's all GI section and workshops. So there's a big boom now in people looking at the dysbiosis, inflammation, interaction, diet, antibiotic use, and trying to really stewardship, in the ETI area, how to improve GI symptoms. It may not be just the ETI, but maybe that we adjust the diet, and does the dysbiosis really associate one-to-one with symptoms, or what else can we do? And then there's this whole topic about colorectal cancer, and people are doing studies to see what predicts colorectal cancer and what are the risk factors. So stay tuned. I think that will be a great year for GI.
Yeah, I agree. I think endocrine is also just kind of starting to wake up. So I think, as I said before, I think seeing the effects of ETI in terms of blood sugar control in both people with CFRD and those without, I think it will be interesting to see the effects of this therapy in terms of muscle and physical activity and how that relates to glucose control. And then I think the other really interesting thing is which targets we should be aiming for in terms of blood glucose levels for pulmonary and nutritional outcomes.
I just had a question, sort of in each of your categories. Is there any other data we should look at in the registries, or just for those that are not eligible for highly effective modulators, or something that we should be paying attention to for the kind of categories you talked about? I think we talked about personalized medicine, and there will be patients for whom stewardship is not necessary. I could think of that example, but if there's anything in your area that we should be aware of?
I'm sitting here like rattling. That's a great question too. So I guess my initial thoughts are, so for the Stop Peds pilot, for example, that was the study that looked at the 63 children randomized to either the standard of care now, which is antibiotics and increased airway clearance, versus increased airway clearance alone. I mean, to me, that is like a jaw-dropping result to see that you can avoid antibiotics in 70% of the time. And that is mostly pre-modulator kids as well. So I don't think I made this clear, but the next round of Stop is going to be in ETI only. And we had a big discussion about this. And I will say we all pushed hard on including the non-modulator eligible children, but we were afraid that if it's such a small number, it was going to not be representative or generalizable. So essentially what we're doing is the main Stop Peds study is going to be ETI, children on ETI, but then there'll be two more pilot studies essentially. There'll be this 2 to 5 year old study, and then there'll be the non-modulator eligible kids, with the plan being, I hope, that if the results are still encouraging that you can avoid antibiotics in a certain proportion of children not on modulators, then a larger study could be done for that population. My personal view is we use too many antibiotics anyway, whether you're on modulators or not. And most of those studies that I reviewed are not people on modulators. So I kind of think of it as opportunities to use or at least limit or tailor antibiotics in everyone. With that said, if you're not super comfortable doing that, I get it. And at a minimum, I think trying to start with the ETI population makes the most sense.
Yeah. So I guess I would, I think I'll put my DEI hat on for a minute and say, when we think about the registry data, and particularly patients who are not modulator eligible, as well as patients who aren't on modulators for unclear reasons, I would encourage us to look beyond the registry data, and I know that's more challenging, but a lot of times it's easy to make assumptions, right? So make assumptions about, it's access, it's insurance, right? Which is also equating race and socioeconomic status, which obviously are linked in this country for a reason, and yet they are not one-to-one. But we as providers have a lot of power in these relationships to build trust, to encourage our patients to be on medications if we think that they are of value to them. And so I think there's danger in that single narrative of, certain patients don't trust us. Well, it's our job to figure out how to build trusting relationships so that everyone who can access modulators has that opportunity and feels comfortable discussing with us. So I think that will be the challenge. I'm also quite curious. The last paper that I referenced spoke to an increasing prevalence of CF in marginalized racial and ethnic populations. And I do wonder, some of that may have to do with the fact that there is more and more interracial marriage and partnerships happening in the sense of perhaps more introduction of Delta F508 and other kind of more classically white European genes into folks who identify as racial and ethnic minorities. But I do wonder if some of it is that we are finally waking up to the fact that CF is not just a white disease, and so we're looking for it more and actually diagnosing it more, and that prevalence has always been there. And again, that's on us to figure out ways to look better and to diagnose better, and really listen to our patients and go out and find people who would benefit from these therapies.
I think the ETI gives us a chance, right, not only to see what is improving, but actually to then look what was wrong in the first place. We learned like how much really CFTR interacts with mucus dysbiosis and our symptoms. We have to link that, and we're not that good yet. And I think since ETI has shown not to resolve all ETI problems, or many not, they may be similar to those who are not on ETI. And what I think is what now comes all on research, and people look at dysbiosis and mucus and do this intervention in mice. But I think we should get better also clinically. So far we all do empiric, even as a GI doctor, you do empiric treatment, like patient has pain and you throw a couple of drugs and see if it gets better. But I think these studies show us that also in clinic we should start doing more detailed studies and targeted, personalized, individualized therapy, even if you don't have that modulator yet for these patients.
Yeah, so something that I actually didn't really talk about today, but in type 2 diabetes, there's been kind of a real expansion in terms of the drugs that we use. So these are the incretin agents like GLP-1 agonists, DPP-4 inhibitors, and I think it would be nice to know what the use is like in the CF population. And I think that there is a potential role for these medications in select patients. So obviously personalized medicine in that respect, especially as we see the population, a greater percent of them being overweight and have obesity. And so I think that would be a really interesting area to see some more literature and database studies from.
And the last question I have, which there's really no answer, but during this meeting, we're talking about genetic therapies, and it's almost always appropriately targeted to those who are ineligible or intolerant of highly effective modulator therapy. But once it comes out, and then what will be the role in these in people who are on effective therapy, say who have an F508del mutation? Would you expect in your areas that you would see further improvement over what we're already seeing with ETI if you put in gene therapy? I mean, have we already maxed that out? Because gene therapy is probably not going to be 100% effective. I don't know if anyone wants to comment on that. It's something I've been thinking more about what will be the role in the people who are eligible for highly effective therapy.
Maybe if lung is the leading organ, they should answer, but the GI symptoms are there, and certainly I think ETI is not, I hope, the maxed out, right? I mean, this is really surprising, after the first observation study in G551D, where Tusi Borowitz showed, the pH is restored, and we all thought, no, that's done, GI is done, right? And we laid back, and then comes Galaxy and the promise and said, oh, they still have pain. And now we did a study, they all have still pain, or not all, but a significant number. And you suddenly think, no, probably when you start early on, you may avoid that. But all the people, even with or without gene therapy, I don't know if switching on that CFTR gene in all organs immediately resolves symptoms. I would doubt that, right?
Yeah. It's more for thought. You're welcome to make a comment.
I think in pediatrics, it just becomes, again, it's a risk-benefit balance, and a lot of that is going to depend on the vector or how gene therapy is administered. I know there's a lot of concern about potential for malignancy with various viral vectors, and certainly, doing that in a 1-month-old or a 1-year-old, if we expect them to have an average life expectancy into their 80s, is a little bit nerve-wracking, particularly because unlike modulator therapy, we can't kind of backtrack, right? Depending on the mechanism, but if you've given it and it's there, I can't take it away. So we're sort of stuck with that. So I do think my impression is that we'll as a group of pediatric pulmonologists need a lot of convincing to jump headfirst into that, particularly because we have modulator therapies as a really impactful interim or in between that maybe gives us a little bit more control over those side effects.
I wholeheartedly agree, and I would also just add again, as a pediatrician, gene therapy is not going to prevent the colds that all the kids get at daycare. So they're going to get the same colds that they get now and then. So there's still maybe antibiotics, and whether that's right or wrong. But certainly, ETI has led to a substantial decrease in IV-treated exacerbations and oral. So I would fully expect if you can get the gene therapy and it's effective and, reduce the chronic obstructive lung disease you get, exacerbations will be much, much milder, and that would be a huge win, obviously.
And Julie, any comment?
I just agree with what I think the same principles would hold with the endocrine beta cell and alpha cell in terms of insulin. Yeah.
Well, I want to thank our speakers. I learned a lot from this. Very good. Good job.